I'm Dr. Michael Miyazaki, and thank you for joining us for another program. On this program, I'm going to focus on bonding zirconia restorations. And as we know, today zirconia is being widely used, and I happened to place a zirconia bridge this week, and I just want to kind of go through with you what the thought process was as I was doing that. So let me get this going. This is kind of the setup. On the left-hand side, I've got my phosphoric acid etchant. It's Velvet Etch, 40% phosphoric acid. Then I've got my quick stat free, which by now you probably all know I love. It's my hemostatic agent of choice, whether I'm dealing with the tooth in front of the mouth or in the back. I've got my regen, my bioactive adhesive. I've got my ZRC and my ZRP. Now, the ZRC and the ZRP are two things you absolutely have to have when you're bonding zirconia. And I have it all the time. So here's the zirconia bridge. It was a 3-unit bridge. What you see on the bottom of the left-hand photo is the old PFM. I cut the PFM off and sent it so lab could match the colors. Now what you see is that it didn't take much to get that bridge off. The front cuspid tooth, the abutment of that bridge, had decay that had been going up under the lingual margin. And we had repaired that area once for the patient at the request of his dentist. He was referred by another dentist to our office to take care of that. And we went up underneath that abutment and we sealed it up. But the patient just felt like maybe there was something that needed to be done more definitively. And of course, we had talked to the patient about this first. There's recurrent decay that goes up underneath an existing crown or especially a bridge abutment. And we're always concerned about, are we able to get all the decay out? In this case, the decay started up underneath the gingiva on the lingual margin, so we had lased that tissue away, gotten up underneath there, and I felt pretty confident that we had it sealed up. But the patient came back a couple months later and said, hey, everything's holding up, but I just have this feeling that maybe something's not totally sealed up. What are my possibilities? So we went through all the different restorative possibilities and chose to take off the bridge, check the abutments, and then if everything was okay, fabricate a new bridge, but one that would not have repaired margins. So here you can see that the zirconia bridge comes back from the lab, and when that comes back, I put that on a solid model. I don't put my restorations, whether it be a single unit or multiple units like a full mouth rehab, on my Pindex models, because the Pindex models and preps could move a little bit and shift. What I want to do is I want to put these on the solid model so I can be sure that everything fits, and it's going to minimize the probability of us having to do any kind of adjustments once the patient's in the chair. So we take the solid model and we place the restoration, in this case this 3-unit bridge, onto the model. Just want to see overall, do I like the color, do I like the fit, are the margins there, were the margins in the impression, in this case the scan, and do I like the way the occlusion looks? I don't want the inclines and the lower cusps to be too locked in, because then the patient's gonna perhaps not feel comfortable when they go into lateral excursive movements. Now, when I place in zirconia, I know we could cement the zirconia or bond the zirconia in, and I'll tell you, 98% of the time I will bond my zirconia restorations in place. Why? Because I feel like it's faster for me. I don't have to place a cement and wait for that cement to harden. I can place a dual cure resin cement and I can cure that, and I know it's going to set faster. I feel that as we bond these restorations to the underlying tooth, that we're going to have a stronger restoration itself. And I know one of the things that makes bonding harder is we have to handle the tissue, both the crevicular fluids that come up and blood. So again, I've talked about this many times. I've got my quick stat free. My quick stat free is my go-to hemostatic agent. It's a clear hemostatic agent, but I find that it works really well every time I need it to work. So here's another patient I saw this week, and it's a second molar way in the back. It had an old crown on it, and there was recurrent decay that got in subgingivally underneath the margins of that crown. I told the patient, hey, we need to take this crown off. I need to see where the decay goes. I don't know if we can save this tooth. So we got in there, and you can see there was a ton of blood. And what I was trying to do is I was trying to put a margin down there and kind of work on the buildup. You can see it was all amalgam back there. and had all this blood there. Now what I did is I just took my QuickStat Free, I rubbed it back there, like not scrubbing it, but just rubbing it around the tissue, around my margins, and I just rinse it off. And you can see it's like night and day. So I love this QuickStat Free. It just works so well, and I would encourage all of you to give QuickStat Free a chance and see how it works in your hands. I use it every day. So step one in the cementation, I'm going to move my head over to the other side, is to try the restorations in. So I popped the temporaries off, I tried the restoration in, and everything fit perfect. The lab had the mesial and distal contacts on the abutments just adjusted right. The occlusion looked good and the color looked good. It was very acceptable to the patient. What you do first is check the contacts. Don't check the occlusion, because if the restoration doesn't seat all the way because the contacts are too tight, then your occlusion is going to look off. So just make sure your interproximal contacts are good, that the restorations are seating up all the way, check your margins, and then check the occlusion. And then in a case like this where you've got 3 units with a pontic, you want to look at the aesthetics. But now once we're done with this, that restoration has been contaminated. There's possibly blood on that's touched the zirconia, and definitely there's going to be saliva. And the saliva has phosphates in it, and so those are what's going to prevent the zirconia from bonding well to the underlying tooth structure. So what we do is we take that restoration out, we rinse it and dry it with oil-free air, make sure it's very clean. And then if you have an air abrasion unit, I would air abrade it just to clean the surface and roughen it up a little bit. Now step 2, this is the critical part. This is where we have to remove the phosphates that have contaminated the zirconia intaglio surface, the internal surface of the restoration. So I use ZRC. ZRC has been shown to be very, very, very effective at removing the phosphates from the intaglio surface of zirconia restorations. So I drop it either from a bottle or a syringe. I use the bottle, so I put a couple drops of the ZRC into the restorative intaglio surface, take a little microbrush, spread it around, and make sure it makes contact with all the internal surfaces of the restoration. Let it dwell there for about 20 seconds, and then I rinse it out. So I rinse it and then again dry it with oil-free air. This is very easy. You don't have to shake the bottle. The ZRC has a very nice orange color to it, so you can see where you put it. And the nice thing about this is I've used some solutions that have colors in it that when you rinse it out, the color stays behind. I have not had this problem with the ZRC. Now step 3 is applying 2 coats of ZRP. ZRP is our primer. It's got 3 different monomers that help our composite luting cements stick to the zirconia. So apply 2 coats of the ZRP to, again, all the intaglio surface area inside that restoration, and then dry it with oil-free air. And what you'll see is it'll kind of blow off, and then keep hitting with air, and you'll see it might rip a little bit, and all of a sudden it'll just be where there's no movement that you can observe. That's when you've got it thinned out adequately. Now you can take your favorite adhesive, as long as it's not too thick. Remember, know what your adhesive is like. I use Regen adhesive because it's a bioactive adhesive, and I just paint that into the intaglio surface of that zirconia restoration, and then lightly air dry it just so we don't blow it all off, because at first the Regen with the bioactive 45S5 glass will have a solvent in it that makes it very runny, less viscous. Hit it with a little bit of air for 5 to 10 seconds. That evaporates out that solvent. Now it's going to be a little thicker. Now with real vigorous air, I just try to thin that Regen out. I don't want it to be thicker than maybe 8 to 10 microns thick. And then you can light cure that into the restoration. So now we've got the internal surface all ready to go. Here's the intaglio surface of that 3-unit bridge, and we're just using the air, the oil-free air, to thin out our ZRP, and then we're going to place our adhesive over the top and light cure that. Now, step 4 is back to the tooth. We've got to get the tooth ready to bond our restoration to. So in this case, I use Velvet Etch. Now, Velvet Etch is different. It's purple, not blue. But the thing I like about Velvet Etch is it spreads really easily. So if you're doing 1 unit, when you place the adhesive on that preparation, I don't want it to be too thick and too difficult to spread out, because if I don't etch the entire preparation, then we could have problems. So what I do is I squirt it out. You can just use the tip of the syringe, or you can use a little micro brush and just spread that Velvet Etch all the way across your prep. And Velvet Etch, again, spreads really easily. It stays where you spread it, doesn't run off all over. You don't want to get the etchant possibly on adjacent teeth where now your composite resin luting cement is going to stick to an adjacent tooth where you don't need that bond. So you want to stay on the preparation. And then once you have spread it easily and it stays right where you want it, it will rinse off easily. So what are we going to do? We're going to place our Velvet Etch, our phosphoric acid onto the prep, leave it there for about 15 seconds, rinse it off thoroughly. We want to get all the acid off, and then get the tooth fairly dry. You don't want to have puddles of any kind of moisture on the tooth. So you can leave the dent moist, but get it pretty dry. And so once we get that area dry and it's clean, and again, going back to the tissue, if I had any concerns that that tissue was going to bleed or weep crevicular fluids, then I would just take my QuickStat Free around that area and then rinse it off and then place my phosphoric acid. That recipe works for me so well almost every time without having to deal with any kind of bleeding. So what we're going to do is we're going to place multiple coats of adhesive, and again, I preferably use the Regen because it has a bioactivity. We will do the same thing we talked about earlier when we use this adhesive inside the restoration, is I hit it with a gentle stream of air that evaporates off the solvent, so now it thickens up a little bit. Now with more vigorous air to really thin it out. Now I thin it out to make sure I don't see it pulled anywhere. I want to make sure I don't see it moving anywhere on my preparations. And then I get in there with my pink wave curing light and I cure for about 20 seconds over each of the preps. I like my adhesive because it's such an important part of this to be well cured. All right, so now step 5, and what my assistant does is she fills up the restoration with typically a dual cure composite luting cement meant for crowns, and she'll fill it up, and I like it filled up with maybe an excess amount of cement, so when I seat the restoration I see the cement coming out from around the margins. It's just like placing a gold crown. If I use in the days when I was in dental school zinc phosphate and I loaded up my gold crown with cement, I sat that crown but I didn't see the cement come out from underneath the margins, then you think, okay, there's a gap there. So same thing, going back to our old training, you take this dual cure resin luting cement, you fill it up. When you seat the restoration, you want to see a lot of that cement come out from around the margins. Now you're thinking, but isn't that going to make it a lot harder to clean up? Well, what we're going to do is we're going to seat it fully. We're going to see all the cement kind of gush out around the margins. We're going to wipe off the excess with the micro brush. I just use the same micro brush that I used when I was applying my adhesive. And then once I get all that gross excess off, I use what you see on the top right hand side, my tack tip. My tack tip is a 2.5 millimeter tip that slips over the top of that 12 millimeter lens from the pink wave, and it takes that 12 millimeters and concentrates it down to a 2.5 millimeter little diameter area of light, and I press my restoration down fully. I watch all that cement kind of ooze out one last time, wipe off the excess if there's a lot. Then I bring that tacking tip up at about a 40-45 degree angle, so it's just aimed right at that gingival tooth margin, and I cure that for about 5 seconds. Now that 5 seconds will just tack set that composite in that area, so that when I release the pressure, if this was a crown or a veneer, or in this case a bridge, it's not going to lift up, it's going to stay down. So I've got that tacked into place. Now all the cement on all the margins will remain on set. Now with the dual cure composite luting cement, we're fighting the time a little bit. It's going to start staying up in a minute or so. So I push it down, wipe out the excess, push it really hard. If there's any more excess that comes out, that's excess, I wipe it off, and then I tack it for 5 seconds, and then maybe on the posterior abutment I tack it for 5 seconds. Now the cement on the lingual and interproximal hasn't set yet, so I get into my floss. So I floss up. Now don't pull the floss back down on this upper bridge, because you could pull the bridge off. Floss up between the contacts and pull the floss out towards the buccal or lingual. If that causes any kind of bleeding, then get in there, wipe off the gross excess, and light cure that really quick so blood doesn't have a chance to get up underneath your margins. Once I do my gross cleanup, getting the large amounts of cement off, I just keep cleaning it, and then I cure. And with the large head of the pink wave curing light, I'll cure the occlusal for 20 seconds. I'll cure from the buccal for 20 seconds. I'll cure from the lingual for 20 seconds. Again, I just want to make sure this thing is just really well cured and set. And then I'll get in there and I'll remove any excess. A lot of times I use like an interproximal carver, and I'll just run my carver up along the tooth restorative margins and watch all the excess cement come off. And I'll run it along the buccal lingual and watch all the excess cement come off on the outside of the restoration. And I'll floss the contacts to make sure everything's okay. So I try to stay focused on the cleanup and not worrying about the occlusion yet, because we tested that, so we know we're going to be in the ballpark. The last thing I'm going to do is I'm going to check the bite, have the patient bite down. Now when they bite down, again, we're looking for even static contacts, but then have them slide left and right, because I just had a patient this week who was a new patient, and she had the upper left second molar, tooth number 15, restored, and it was a zirconia crown. It was done by another dentist. She was just never happy with the crown. Just the tooth always was painful, sensitive, and never felt right. So we went in there, readjusted the bite. Now I'll tell you, I don't always recommend that you adjust the bite unless you're absolutely sure it could be an occlusal issue, just with the more of the static or dynamic occlusal stops, and it's not a TMJ type of problem. So we got in there, we adjusted the CO contacts, bite, okay, even out the pressure points. And then I had her go slide left and right and lateral in very tight occlusion, and she was hitting the incline, so we had to clear all that out too. So she had posterior interferences. And in future videos or programs, we'll talk more about that. So then you adjust the occlusion, get that all taken care of. Now what I really liked was, look at that killer ovate. So that is the missing tooth, but it looks like that pontic or that tooth is just coming out of the tissue. How did the lab get that? Well, when they created the bridge, they modified the model so it had a little dip there. The zirconia fits into that dip. When I went to cement this, of course, it kind of teeter-tottered there, so I really had to push it down hard. Now, if the lab, I had given the lab instructions about how much I wanted them to take that underside of that pontic, how much material I wanted them to take away. But if they had taken off more and that prevented the seating of that bridge, I would just take a burr, maybe take some tissue away there, or your electrosurge, or in my case, I would use a laser and modify that. But we did not have to do that. The lab did a great job. So here's an example of the tacking tip. So this is, again, on the far left-hand side, we've got over here the 2.5 millimeter lens. So the 12 millimeter lens of the pink wave was kind of condensed down to 2.5. When I tack that restoration, or the restoration's in place, it seals up the margins, it prevents movement, and makes the cleanup so much easier. And so that's where hopefully this program is going to make your life easier. Now this is just showing how the week before I was cementing and then bonding in crowns on teeth number 8 and 9, and this patient had really, really long centrals, 12 millimeter long centrals. But look at that pink wave. The pink wave covers the entire facial of that crown. So basically, as I was mentioning before, when I'm curing, I come in and I cure 20 seconds maybe from the facial, 20 seconds from the lingual, and that's going to be adequate. We're not going to have to do a little bit the cervical, a little bit in the mid-body, a little bit at the incisal edge, like some of you might have to do if you had a smaller head. Well, just really quick, that's just a really quick rundown of how I cement or bond in my zirconia restorations. Talked about tissue management with the QuickStat Free. We talked about the etching with the Velvet Etch. Stays where you put it, easy to spread, easy to remove. And then the ZRC and the ZRP. If you follow this, and unfortunately I've had to cut some of these zirconia restorations off, and we've been following the same protocol for a couple of years now, they stay on like they are natural teeth. You get in with a burr and it's rattling, and these zirconia pieces do not just come right off the preparation. they stay on there. They're very tenaciously. So I think this is a great recipe to follow. I have colleagues that have shared with me that sometimes they cement their zirconia restorations, or they even bond them, and the patients eat something slightly sticky and the zirconia restoration comes out. So if you do this, you're going to have fewer calls on Fridays and you're going to have happier patients. All right. Well, I hope you enjoyed this program. Thank you very much for your attention. Take care and hit subscribe.